Good afternoon, ladies and gentlemen, and welcome to the ACOEM Development and Use of Evidence-Based Guidelines webinar. Today's program will outline the development process for evidence-based guidelines, how you can apply the ACOEM Practice Guidelines to clinical decisions based on patient findings, and the time course of the case, and discuss how to document the evidence base for proposed testing and treatment. Today's program is being recorded. There is 1 hour of CME and MOC credit for this program. You received a verification form with today's instructions, or you can follow the link that was in the instructions to access the form. No certificates will be sent to you, but your transcript of this and other ACOEM educational programs can be viewed and printed from the ACOEM website. Members and non-members can both view their transcript directly from the website. Today's program will consist of approximately 45 minutes of lecture and questions at the end. We will address questions as time permits and suggest you submit your questions early for consideration. We are only accepting questions electronically. On the screen, you can see how to open the question box in order to submit your questions. This was also in the PDF file of the handouts you received with the instructions. The educational activity presenters and planners have indicated they have no disclosures to be made. It is my pleasure to introduce our presenter for today, Dr. Jeffrey Harris. Dr. Harris, you may begin.
Thank you, Sandy, and I hope everybody is online, and hopefully this will be an enjoyable experience. I'm going to go relatively quickly because a lot of these slides are self-explanatory. And one of the first things about guidelines is you should know who wrote them and whether they have any conflict of interest and what their backgrounds are. So that's the purpose of this slide. I don't have any conflicts to disclose. I don't get paid for anything on this list except for working for Kaiser Permanente as an active clinician. So we're going to do this in 2 parts. The first, I want to run through what evidence-based medicine is and why it is an advantage for patients as well as healthcare systems. And then, primarily due to popular demand, I guess, and a certain number of misunderstandings, go through how evidence-based medicine is used in utilization review and payment decisions. We started doing that because these guidelines are presumptively correct in California, but I understand they're used in a lot of other places as well. So really the goal of evidence-based medicine in occupational medicine is to reduce variances from best practice. One of the principles of quality improvement is that variation, with the caveat that it doesn't include variation in actual patient situations such as allergies and so on, tends to be a sign of poor quality. Most of the guidelines you see have to do only with treatment, but in the case of occupational medicine, it's important to cover all of the areas that are listed on this slide. And in particular, most of the cost of workers' compensation is spent on a small number of chronic cases. So pain management and disability management become relatively critical. Now, the question, of course, is, well, what's wrong with variance? We get told all the time that every patient is different, and of course that's true as far as their personality goes, but not necessarily as far as physiology is concerned. Otherwise, it would be impossible to do any randomized trials of pharmacology and so on. Don Berwick, who at the time of this quote was the president of the Institute for Healthcare Improvement, is now the head of CMS, the Medicare and Medicaid agency for the federal government. And he pointed out that the amount of variance he was seeing, and this was general medicine, but it's actually more significant in occupational medicine, amounts to a roll of the dice. There's just sort of random things thrown at people. And as John Wenberg from Dartmouth, who Bob McClellan, who's on this call, probably knows, if you have random treatment, you end up with random outcomes. So you really can't be very reassured that you're going to get what you're looking for. one of the misunderstandings about evidence-based medicine is that it's an instruction book you have to follow. That's really not the point at all. This quote is from one of the classic books about evidence-based medicine, and if anybody's interested, I put the reference there. It's an excellent teaching book. The idea basically is that you're trying to look at the best evidence and then fill in the gaps with clinical expertise, bring decision-making with best evidence to the bedside, as opposed, again, to relying on experience, which tends to cycle and not necessarily be completely evidence-based. And so, again, Dave Sackett, who I think started a lot of this, came up with this definition. Now, David Eddy, who is somebody who's been involved in evidence-based medicine and simulation models for years, expanded this to look at the entire healthcare system. So the idea here is to use the best evidence of effectiveness across populations so that the system can take care of everybody in an effective way. Now, people will periodically say, well, let's get rid of this stuff or block it. The problem basically is that there is no better substitute. There's very clear evidence now that following evidence-based guidelines results in better outcomes, and there doesn't seem to be any alternative model. Just to go through what guidelines actually are, the National Institute of Medicine came up with this original definition about 20 years ago, and it really hasn't changed. One of the key points here is that the statements are systematically developed, and we'll go through what systematically means. That's a key point. And that it's for specific clinical circumstances. Again, we'll go through that. So a guideline is nothing more than a collection of specific recommendations. Why do we bother to use guidelines? Well, aside from the fact that variance isn't particularly good for patients, healthcare organizations, and payers are demanding quality care. They're looking for good outcomes and medical safety. They don't want unexplained and unwanted variation. And there's really no point in paying for or even doing unproductive or harmful procedures. Most consumers want practices that reflect advances in medicine, but they want them evidence-based. I spend a lot of time with my patients answering questions about what works and what doesn't. And sometimes I have to resort to saying, well, the last 10 people I saw reacted this way, but that's not statistically valid and probably not scientifically valid. If you're evaluating guidelines, this course is about the ACOEM guidelines, but again, caveat emptor, before anybody adopts a set of guidelines, they ought to assess them. This list is one we put together about 13 years ago in a JOEM article. A lot of it was taken from National Institute of Medicine information. And now there's a new tool for evaluating guidelines called AGREE-2, which I didn't put a slide in here on, but you can Google it. It's capital letters AGREE, Roman numerals 2. And that assessment tool is international and relatively well validated. Why does methodology make any difference? In other words, why does it make any difference how we put these things together? Well, basically, how rigorous the methodology is directly correlated with how reproducible the recommendations are. 2 points to remember are that critical appraisal of each study that you find and synthesizing the studies are critical steps. Simply repeating what's in the study or the National Library of Medicine's label doesn't really tell you whether the evidence is any good or whether the body of the evidence points in one way or another and how consistent it is. And secondly, there's clear evidence that panel processes by trained clinicians improve the consistency and risk-benefit ratio of guidelines. There are no internationally accepted guidelines and no government guidelines for the VA or other agencies which don't use a structured panel. That's true of the National Institutes of Health as well. There's some guidelines out there that are done by single authors or a couple groups, a couple of people. They don't fit this definition at all. So when you're looking at guidelines to decide which ones you'd like to use, the first question is there a published, detailed, comprehensible, and generally accepted methodology? Now, in all the guideline panels I've worked on for ACOEM and Kaiser and several other groups, there's always a methodologist on the panel who's sort of not the police, but the traffic cop to make sure that the methodology is followed properly. You'll see what that is shortly. But basically, the questions are, was the evidence search systematic? Was there critical appraisal and evidence grading done, and was it done well? Were the people who did the grading appropriately qualified and trained? And that generally means either a medical professional or somebody with an MPH or a statistics degree. And were the recommendations made systematically, again, by properly trained, broad-based healthcare professional panels? So we're kind of ruling out people who have English degrees or history degrees or marketing degrees, and really focusing on people who understand what the content of the guidelines are. Finally, you need to make sure that the recommendations are scientifically valid and clinically valid. I've been a peer reviewer on a number of reviews where things are statistically valid but don't quite make sense clinically, and so we're big on having clinicians on these panels. The basic point is that you want the test, if you're evaluating tests, to reproducibly and consistently detect a condition which is clinically meaningful. And in the case of treatments, whether the treatment is reproducible and consistent in helping the patient return to function. One of the key points here is it has to be better than the natural history of the condition. There are a lot of studies that are head-to-head of one treatment against another, and they leave out the placebo arm, and it turns out neither one of them is better than just not doing anything and letting nature heal the patient. One other point to notice is that there were separate streams of analysis, of systematic reviews and meta-analyses, which are terms of art for evaluating studies, clinical practice guidelines. And now, especially in Europe and the UK, they're using guidelines to go through a relatively complex process to derive quality indicators that are then used nationally for quality improvement and even for payment. The UK was the leader on this. It's starting to happen in Germany and Holland, and it's possible it will appear here. Healthcare organizations are applying it already. It's not going on with government programs quite yet, I don't think. There were separate processes going on for improving safety, for health technology assessment, and even for impairment evaluation. They're all starting to converge using evidence-based, and even Cochrane Collaboration is now doing evidence-based searches for public health and healthcare policy for the European Union, and it seems to be making considerable difference. So let's just very briefly look at the ACOEM methodology itself. This started with the revised second edition, and in developing the methodology, a group of us looked through the international literature, looked at the methods, put the steps and processes together, and looked at analytic tools and rating scales. Here's AGREE again. We tried to match the AGREE domains and criteria. The committee that were the co-authors of this article in JOEM went through the findings several times, revised them. We sent the methodology itself out for peer review and then published it in JOEM. So what the methodology contains, and you're probably going to see these lists over and over again, so I'll try to go quickly, but it bears a little repeating. First of all, you have to ask an answerable clinical question. So it's not, what is good for tonsillitis, although that's not a totally unreasonable question, but something as specific as you can get it, which specifies which population you're talking about, that's the person, which intervention, what's the comparison, which hopefully includes a placebo arm, and what's the outcome. And generally we're looking for final outcomes like function. In the case of things like cardiovascular disease, looking for things like mortality or serious events. Those are uncommon in occupational medicine because a lot of what we're talking about is musculoskeletal pain. But that's an internationally accepted way of asking the question, and that directs the researchers to go do a search of electronic and paper resources to see what studies they can find about the topic you've posed. There are a lot of them. I don't remember the number in the low back guideline, but there are hundreds of them. But everything starts with a good question. You can set up criteria to include or exclude certain studies that have to do with language, the number of people in the study, perhaps the time frame, and so on. There's an electronic search done, followed, generally speaking, by looking in bibliographies and talking to authors and tracking things that way, because it turns out the electronic databases are rather significantly incomplete. The next thing you do is, once you've found studies that pass the inclusion criteria, trained professionals will grade each one of them for quality, summarize the high-quality studies, and grade the body of evidence. Now, just to give you some examples, these are things that we evaluate for treatment studies for the second and third editions. And they are, again, a relatively well-accepted list from the international literature. You can read this. Some of the problems we get into with some of the occupational literature and musculoskeletal literature is a lack of concealment or randomization. Sometimes it's hard to blind the intervention because it's a physical process and you have to come up with some sort of sham. Controlling for co-interventions is big because people tend to do about 5 things at once in some of these studies, which of course doesn't make a lot of sense. You can't take apart which pieces of it actually work. It's particularly true of things like physical therapy studies. The compliance has to be acceptable, and that can't be changed post hoc. We'll see studies where they'll say, well, we offered 30 sessions, and we've now decided, since very few people went to more than 8, that 8's okay. That messes up the statistical power of the study, and it's not really a good idea. Another thing we see in a lot of these studies, particularly things like opioids and some other drugs, so up to half of the people will drop out due to side effects or the fact that the stuff just isn't working. So that's fairly critical as well. And then the timing of the assessments. We've seen studies where they'll assess what happened to the placebo arm at certain points and the treatment arm at other points, which of course doesn't make any sense. The grading system that ACOEM is using at the moment is this. You can read it here. High quality is defined as, I think, having a score of 8 or better on that scale I just showed you. And so when you read the guidelines and see those ratings, that's what they are. So a systematic review, just to do this very quickly again, is following these steps. This is internationally defined as what systematic is. At the bottom there, heterogeneity means that you want the results going in the same direction with roughly the same magnitude, and you don't want the confidence intervals crossing 1. The ACOEM literature searches, which are done in Chicago and Salt Lake City, are exhaustive searches mostly for randomized controlled trials for treatment. Not just the Library of Medicine or Medline or PubMed, but a lot of these other databases, and there's several others that we use sometimes as well. The researchers will create abstracts and summary tables of each study so that the panel can see what's going on there and the methodologist can make sure they did their job right. Then they generate summary paragraphs about the body of evidence discussing how the outcomes compare or differ. And then the panels, which have been through training programs, will formulate draft recommendations by looking at some of the summary documents. They're sent all of the original studies, but that's a whole lot of stuff. Some people read them, some people don't. There's a multi-stage review process for methodological accuracy. There's editorial review. We send the guideline chapters out to many, many organizations, pretty much everybody we can think of that would have an interest in them. There's pilot testing in some organizations, and then there's a repeat of the process every 2 years. The recommendations are based on the evidence syntheses. The methodology we're using at the moment locks the level of recommendation to the level of the evidence. And then the gaps in the evidence are filled by structured clinical consensus, often with facilitated discussions. I think we've only had to use ranked voting a couple times because we can reach consensus before we get there. You want to apply first principles, which I'll show you shortly. And the major consideration is balancing the risks and harms against the benefits. And then after you're done with that, think about resource allocation. But primarily what that means is don't do things that don't work and don't help people out. Now the first principles, there are actually about 15 of these. I just showed you a few of them for illustration. These are just common sense things that most people would do if they thought carefully about their clinical practice. Ethics is pretty self-evident, and you want the recommendations to be evidence-based whenever possible. Now, treatment, as I've mentioned, should improve on the natural history of the disease, which in the case of a lot of musculoskeletal problems is spontaneous recovery. That may be hard to believe given the sort of skewed sample of workers' comp patients a lot of us see sometimes, but if you look at population studies, that's actually true. Best practice treatments, particularly in prioritizing treatment modalities, and when there are options, which you will see in the guidelines, choose the one with the best evidence behind it. When you're managing somebody, the idea is to precede invasive treatment by adequate conservative care. Now, this does not apply to emergencies. Obviously, if somebody's broken something or has caught Aquinas syndrome, this is not an issue, but that's not mostly what most of us see. It's more ongoing type of things that are more medical than surgical. And you want specific goals that are stated before you start treating somebody. We used to do this in our head, and now it's really a good idea to write it down so you can see whether you've gotten to the goals or not. If you don't get to the goal, it doesn't mean use things that are less effective and more risky. The calculation doesn't really change depending on the time of the case, because if you do that, the patient is more and more likely to be put in harm's way. One of the key principles of disability management, which I think we all know, is that it shouldn't be creating dependence on modalities or functional disability. Invasive treatment is okay if it's evidence-based and conservative treatment fails. The more dangerous and permanent something is, the more you ought to think about it first. Finally, internationally, there's a big emphasis now on shared decision-making. There are medical legal reasons for this, but it also turns out that people do better if they're sharing the decision. In fact, at Kaiser, we're evaluated for that. That's one of the patient survey questions. So now this is about what recommendations look like in the ACOEM guidelines. All of these points have to be covered, and you'll see shortly that when people do utilization review, they're looking for this information. But this also is something, if you were a resident again, somebody would be asking you about in reviewing cases, and they do the same thing in quality assessment. So one of the points, obviously, is how many of something should you do. So in things like physical therapy, where you're asking, or chiropractic, you're asking for a series of things, or even epidurals, you need to talk about how many you should be doing in this particular plan. And then also note harms and benefits. It's actually pretty quick to fill this out if you create a template in your electronic medical record or have printed forms. And then you have a complete set of things that you can think through and discuss with other people. And, you know, I do a lot of quality review of charts, and these are the things we're looking for. So here are the recommendations you're going to find in the ACOEM guidelines. They are linked to the evidence base again. And so in A, strongly recommended because there's high-quality evidence, and the panel concludes benefits outweigh harms significantly. B is less well-backed, but the benefits are still way ahead of harms. C, it's not really good evidence, and it's not clear exactly what's going to happen. There are insufficient evidence situations where there are panel consensus, and these are we don't have enough to say about it, or there's not clear evidence, but a clear consensus that it's a bad idea. And then not recommended moves in the other direction, from limited evidence that it's a bad idea to strong evidence it's a bad idea. Now, when you're looking at what guidelines to use, so we're trying to be a little broader than ACOEM guidelines, you're going to see stuff like this. This came off the Oxford Center for Evidence-Based Medicine website. It exists in other places. This is the level of confidence somebody would have that a study design, if executed properly, would produce reproducible outcomes. Now, here's the problem with this. This is a design. It doesn't talk about execution with all those criteria that that I showed you earlier. So it's fine to say that something has one of these ranks, but it's really not useful information until you actually read the study and find out how well it was executed. And this one is for testing, otherwise known as assessment. Basically, you want something with an independent blind comparison, appropriate spectrum of patients, the same test, and the same reference standard, which is known as the gold standard in some of these slides. But again, this is a hierarchy of design, and it's not how things were actually executed. Here's the rest of that slide. There are other slides like this for prognosis and harms and different other things, but this is a good place to start. It is clearly not the entire process. Now, ACOEM and pretty much every other international group I've worked with, which includes a cross-international comparison I did for the British Society of Occupational Medicine last summer, does not accept any of these types of things as evidence because they're irreproducible. I was just at the Cochrane Collaboration Conference, and there were a whole series of presentations demonstrating the lack of accuracy or objectivity of industry-funded studies. And yet it turns out that a lot of our studies are industry-funded, and a lot of the panels that some agencies are using are conflicted out, which is rather unfortunate. So you have to really look at the source of the evidence. A lot of, well, some guidelines, there is no conflict of interest statement. This is not a good idea because of the degree of research support that's now going on from pharmaceuticals and device manufacturers. And other guidelines aren't used because they have to go through an entire rating process with AGREE, and it turns out that it takes a lot more time to do that than it does to start over again, although the Guidelines International Network is trying to reduce that since it's not very efficient. But I think what they're going to come up with is a proposal that if guidelines are internationally accepted, they have to go through a rigorous evaluation. Now, this is a list of things we found. Kurt Hegman and his team in Utah and Julie Ording in Chicago. These are generalizations, but they hold pretty much true. A lot of studies aren't listed in PubMed. Cochrane Collaboration recognizes this, which is why they talk about hand searches in their handbook. Go into looking at other databases. Hand searches means looking at the bibliographies of really good articles, going through your literature collection, asking panel members, and so on. We've already talked about ranking things by design. It just doesn't work. Now, one of the points we discovered is that many systematic reviews and meta-analyses are not systematic or critical, although they tend to be labeled that way in PubMed. Cochrane reviews are usually very well done, but there's a caveat that some of them are done by non-clinicians, and so the clinical significance of some of the statistical conclusions has to be looked at. Diagnosis is absolutely key because studies are done by setting up inclusion criteria based on either symptom clusters or diagnoses. And that's the reason there are diagnostic tables in ACOEM chapters, and it's required in the methodology. As some of you are probably aware, diagnoses tend to be very inaccurate and reproducible in occupational medicine, I'm sorry to say. But if you've done enough chart reviews, you'll see this a lot. If you don't have an accurate history and physical so that you can use the diagnostic criteria, you're kind of stuck. And if the diagnosis is wrong, you're going to go down the wrong pathway. In a lot of what we deal with, the neurological exam is absolutely key. It was interesting, quite some time ago, we had a Robert Wood Johnson grant to evaluate the guidelines and then do a lot of teaching. And we were teaching in a couple of very large companies based in Detroit using the electronic feedback tools that I think a lot of you are familiar with, where you vote on the keypad. And when we started, we'd do a pretest and find out that people's neurologic exam skills were really not very good. They were in the 20% accuracy range. And by the time we got done, Bruce Dalton, who has worked on this previously used to be with the Army, and he insisted we actually walk through the book and have people show where they found answers to things. By the time we were done, that sounds sort of boring, but we'd raised the accuracy level to about 90% on the neuro exam, which is really critical. A lot of the things we use in maneuvers, turns out when we've done reviews of their accuracy, they aren't particularly accurate. And I'm not aware of any studies of what chiropractic maneuvers mean or yield, which is a problem. So which guidelines do you want to use? Well, obviously, I'm sort of biased because I've done work on the ACOEM guidelines, but I've also worked on the Pain Society guidelines and the Kaiser guidelines. I'm actually the methodologist who is rewriting their guidelines or their methodology at this point. So, you know, I'm more interested in accuracy than I am with, I'm trying to expose everything here. So when you're deciding which guidelines to use, you want them to be comprehensive. You want diagnostic criteria, and I would strongly recommend you also have the mechanism of injury, because otherwise it's what's statistically correlated for known mechanisms that are really work-related, or it's guessing as far as whether work has anything to do with it, which has payment implications, but also implications for protecting workers. It doesn't make sense to go doing a bunch of ergonomic stuff when there's no link. They have to be methodologically sound. They should be transparent so you can tell what's going on there with references and so on, disclosures. Presumptively correct just applies to the jurisdictions where there is a presumptively correct guideline, which I think is now 8 or 10. California, Montana, Hawaii, New York just adopted some, and there are others. So robustness is one of the agreed domains. It's one of 6. And you've seen this list before, but when you're doing an agree evaluation of a guideline, you go through this as part of the checklist. So that's how the ACOEM guidelines were put together, and some guidance for you when you're trying to decide which guidelines to use in your practice. Now we're going to go through how this is used in medical management. Some of this applies to utilization review, but it also would apply to managing a group or even just managing your own patients. Now, utilization management, which is usually the target of most of the slings and arrows in this particular discussion, isn't really what people think it is. I keep hearing over and over again that they're high school educated clerks turning down requests. It's all about saving money. Well, first of all, I'm not aware of a reasonable insurance company that employs people like that, and most state laws don't, I mean, they're there, but they're not doing utilization review. Most state laws do not allow non-professionals to say no, and so there's almost always review by a trained healthcare professional, either a nurse or a physician. Most insurance organizations and review organizations are now using evidence-based guidelines and medically trained approvers, or reviewers rather. The leading causes of non-approval are not because people are being obnoxious and just random. And I've reviewed, I would guess, 5,000 of these charts. A very large number of them have illegible or incomplete documentation. When people call to get the information, more often than not, they don't get a call back. And a minority of them have, once you get past all that, a request inconsistent with proven effective testing or treatment. There are a fair number, but the top 2 are actually the worst problems still, even 10 years after we've started, actually 15 years after we started teaching about this. So in managing care, the first thing to do, say you're the medical director of somewhere, make sure the diagnosis and the mechanism of injury are accurate. Check out if there are any functional deficits or not, which makes a big difference. You're either dealing with a functional problem or pain. More often than not, it turns out it's pain, and whether or not there are functional deficits, they're not documented. And then put together a treatment plan, which is logical and uses effective information or effective techniques. If you're the reviewer or the supervisor, you'd want to approve and proceed with this incrementally and keep an eye on the goals. Now, what happens if there is no evidence of effectiveness? Well, then you're on the right hand as you're facing your computer side of this diagram, trying to see if this is clinically logical, but also keeping an eye on function. And if function is not improving, then you don't want to keep doing something because it really isn't solving the problem. This is part of the second edition. It's probably going to go away in the third edition. I haven't seen the end of this yet. You have to watch out for unproven things and do that by looking at patient response. That's a test of an N of 1. There's a name for that kind of test. The way that's classically done is you start something and then stop it and see if the benefit goes away. That rarely happens in clinical medicine, although it's done in oncology because it's the only way to test some of these things. But in musculoskeletal medicine, if you're going to do something that's apparently beneficial but the evidence isn't very good and clearly not harmful, you might want to do an N of 1. A lot of people don't really like this. So again, you're using effective treatment for specific diagnoses. Emphasize therapeutic activity. There's the best evidence we have about most pain conditions like low back and arm and so on is to increase activity, not to do modalities. And again, if you look at the epidemiology of most of these conditions, there are a few really good books that are unfortunately a little bit old now, but the recovery curves are days to weeks without doing anything. And so the reason you don't do invasive treatment right off the bat, unless there's a very clear indication like cauda equina or something's broken or lacerated, is that the benefit to risk ratio changes depending on how far you go along. In general, and this is probably no news to anybody on this webinar, musculoskeletal treatments generally are non-surgical to start out with unless you have red flags, which are things that are dangerous and should be referred right away. Surgery is done to correct a clear anatomic defect after conservative treatment failed, again, assuming this is not an emergency. And the evidence for the effectiveness of invasive pain control procedures is, in general, not good and tends to show they're either ineffective or dangerous. Obviously, that's a gross generalization. And later in the webinar series, when we start looking at specific body parts and specific treatments, we'll go through that evidence. This is more of a general overview today. When you're looking at requests to do things or one of your colleagues wants to do something, look for these contraindications. They should be obvious, but we've seen a lot of requests that ignored this. We've seen morbidly obese people given surgery that probably wasn't necessary in the first place and dying on the table, and that's obviously not a good risk-benefit ratio. So the focus of medical management then, whether it's done by an outside organization or quality management inside an organization or in your own practice, is to improve function. Pain management is necessary but not sufficient. There are a number of folks who don't agree with that, but if you read the Pain Society guidelines, which I just did a comparison across guidelines, they're always talking about function. Pain management is a secondary issue, which is rather interesting considering who they are, but they're coming down very clearly on that. So again, you're looking at functional recovery against a treatment plan. One of the key points here is if something doesn't work, don't keep doing it over and over again. That clearly doesn't make any sense. And look for reasons why progress is not occurring, which are yellow flags. We'll find out if they're in here or not, but they're in the guidelines. So again, you're looking at, this is getting a bit redundant here, but it's redundant because people keep forgetting about it. One of the things to look at is the work-relatedness of current proposals and requests, and sequence the timing. It turns out that people are treating a lot of stuff that turns out not to have very good evidence of work relationship. One of the key points about chronic cases is if they were treated effectively, and this means both disability management and doing things to people early, they probably wouldn't become chronic, and that includes setting expectations. There are a lot of people who have very unrealistic expectations about what's going to happen to them or that they won't recover, and one of the jobs of the clinician, obviously, is to work with that. The criteria don't change, so you don't just start throwing imaging at people because they've been out for 4 weeks, because if there's no clear reason to do it, it's going to uncover a lot of false positives that you probably don't want to find out about because they're useless and they send you down the wrong path. So the yellow flags are in Table 5.1 in the second edition. Misdiagnosis is a possibility, but it's usually not the issue. Make sure the diagnosis is right, again, and review progress to date. The elephant in the room, and I'm just going to comment on this briefly, is that the evidence for work-relatedness of an awful lot of things that we see is not very good. I was at the Occupational Health group of the Cochrane collaboration, and they do have work-relatedness on their agenda. They're looking for reviewers if anybody wants to start doing Cochrane reviews. You can contact Joseph Verbeek in Finland. But so far, the ones they've done are not finding a whole lot of good literature. Prospective cohort studies would be best, but they are limited at this point. And there are obviously regulatory and policy issues about whether something is work-related. Healing time versus chronicity. If something's not getting better, you really have to document that they're still exposed to some known risk factor at work. An awful lot of these people aren't working, and so the question is, where's the exposure coming from? Not at all clear. And a lot of the diseases we're now looking at are actually diseases of aging, like arthritis. So pre-certification, real quickly here, is a subset of care management. You've seen this slide before, and you can use it as a guidepost for submitting requests or looking at requests. Here's the recommendation format again. And again, you could convert this into electronic format or you could use it printed. But this is what reviewers should be looking for and what you need to present to make sure that you get what your patient needs and don't get what they don't need. The diagnostic testing and physical therapy are sort of special cases. Testing only if it's going to affect the course of treatment and done to confirm a clinical impression. Simply fishing is not a really good idea. So you verify the diagnosis. This looks redundant, right? Well, it is, but I don't know why people keep falling off the rails on it, so I'll just go quickly through this. You want the patient to want to do something about the findings if you find them. A lot of people say, well, under no circumstances will I consent to surgery, and then the question is, what are you actually looking for? Is it going to make any difference? Imaging caveats. I don't know how many of you know about the rule of decades, but in MRIs, CAT scans, and plain X-rays, somebody who is 40 will have a 40% chance of finding something which is called abnormal by the radiologist, but doesn't necessarily have any correlation with symptoms. And so fixing that, if there were a risk-benefit positive, probably wouldn't have any effect on what's going on with the patient. This is a real swamp that people get into, and one of the reasons why you only want to do these things if you have a reason to do it. Same thing with electrodiagnostic studies. They correlate with, you want correlation with a neurologic exam, not Phelan's and Tinel's, because they're very insensitive and nonspecific. They're a good way to go if you have clear radicular findings with, or clear story of radicular symptoms without clear physical findings. But then that's a rule out, not a rule in. Physical therapy, the problem is basically that you're trying to do this by what they're using as opposed to sessions. There's very little research on, quote, sessions, because for those to be comparable, they would have to have the similar protocols, which usually doesn't happen. Some of the better research does have a similar protocol, but there are real problems with dropout rates or somebody finding out that the other arm's working better and switching without telling the investigator. So again, you need to look at the studies very carefully. Anyway, the research is done by treatment, not by sessions. So what you're left with is looking at functional abilities and goal achievement and proceeding incrementally, not just saying, okay, have 12 and then we'll talk to you later, because that's usually not good for the patient. Modalities are intended to reduce pain. They have a limited duration of action, and the question is, do you really need a licensed health professional to do this? The answer usually is no. Again, the point about activity is very important. Holding still is not good, so then we get into fear avoidance, which we may talk about later. Treatment should be directed at documented functional deficits. And again, do you need a licensed health professional? This is a summary of why visits doesn't really work. I talked to the head of physical therapy down in the University of Dunedin in New Zealand several years ago. She was head of the Cochrane PT group, and she finally said, you know, it really is a black box, and that's a problem for research. So management to plan, once again, and management against functional deficits. You know about what's in these lists. When you're asking for this, make sure you do a plan that looks like the ones that we have talked our way through here. So I think we're down to CME questions. Sandy, do you want to do CME first or questions?
Sure, I could take some CME questions and remind everyone to please submit their questions electronically so that Dr. Harris can review those and be able to have some time to answer those at the very end. So we're going to go through the CME questions. The first question is, how does evidence-based medicine improve medical quality? Number one is adherence to evidence-based guidelines should reduce practice variance. 2, adherence should reduce use of unproven or ineffective tests and treatments. 3, evidence-based guidelines reduce doctors' flexibility. 4 is answers 1 and 2. And 5, your fifth option is answers 2 and 3. And the answer to this question is 4, which is 1 and 2. Or, yes, 1 and 2. The second question. Common reasons that requests for pre-authorization are denied. 1, absence or unclear documentation. 2, review by uneducated personnel. 3, redundant or inappropriate tests. 4, a focus on saving insurance funds. The fifth option is 1 and 3, or the sixth option is numbers 2 and 4. And the correct answer is 6, which is 2 and 4. And finally, well-accepted steps in developing evidence-based guidelines include 1, a systematic search of literature. 2, critical appraisal of identified studies. 3, critical appraisal of body of evidence. 4, formulation of logical evidence-based recommendation. Or 5, all the above. And the answer here is 5, all of the above. Dr. Harris, at this point, I don't see any questions submitted from the attendees, and it's time for the Q&A session. If there's something else that you want to address during this time, you could take the time to do that. And while we conclude the last few minutes here, I will pull up some overall evaluation questions and ask that you provide us with some feedback on today's webinar. Dr. Harris, the floor is yours again.
Okay, well, I guess one thing I'd like to point out, this probably was kind of wonky in terms of methodology and so on. It was partly presented so that you'll understand how the guidelines are put together, and the guidelines mean ACOEM, but others as well. And then secondly, so that if you're choosing guidelines to manage your practice, you can choose ones that you are confident in. The next 3 webinars are going to talk about specific evidence reviews and recommendations that are made for different body parts. So this is the overview and the introduction, and then we'll actually go through what came out of very extensive literature reviews and panel recommendations. So if anybody has anything they want to ask, you can key it in. And I would be willing to answer things by email later if people think about it and want to ask some other things. I don't know. Sandy, do you have any information about when the 3rd edition is coming out?
No, I do not.
think it's later in the year, but I'm not positive. So it looks like the next webinar is hip and groin disorders next Monday. This one was done as a joint project with the American Academy of Orthopedic Surgeons, so it should be interesting.
Well, if there are no questions in the queue at this point, any other final comments, Dr. Harris?
Well, I don't have any, but I'm one of these people that wakes up tomorrow with the questions, so I'm leaving the door open. Maybe they could send them to you, Sandy, and you can forward them.
Definitely. The email that everyone received the instructions, you can email those to me, and I would forward them on to Dr. Harris. So at this time, I'd like to thank all of you for your attendance and thank our presenter, Dr. Harris, for his valuable presentation. This does conclude today's program.